Good evening, Namaskar. Myself, Dr. Jay, State Convener of Maha IP. Welcome all to this very important session of today. It's about arterial blood gas in pediatrics. At the outset, I'm very thankful to our both speakers, Dr. Mahesh Mohite, sir. He's chairman of the India Critical Care Society India, and our Satish Devpujari, sir, the senior consultant from Nagpur, and our chief guest, Dr. Basavaraja, sir, and all the audience, I can say pediatrician will join a large number for this important topic of blood gas. When you talk about the blood gas, you know the milliliter of the body is very important to function the body in cells very properly. So again, I welcome you all and let us get pulse of wisdom about the ABG from our stalwart speaker, Dr. Mahesh and Dr. Satish sir. I'd hand over to our further proceeding to our Dr. Samir. And I welcome our ask Dr. Hemant Gangulia sir, our own MyIP president, to give his flu. I think त्याचे विचार त्यांनी सांगावेत या प्रोग्राम बद्दल आणि आपण पुढे जाऊयात. धन्यवाद.
Thank you, Jay, and good evening and namaste to all the respected dignitaries on the dais, as well as the office bearers of Maha AP and the dignitaries of the Zoom dais, as well as the all wonderful, lovely attendees of the Maha AP YouTube channel. Today, really, I myself find fortunate to amongst these stalwart speakers, Dr. Dev Pujari sir, as well as Dr. Mahesh Mohite sir. खरं म्हणजे म्हणायला गेलं तर आपलं सौभाग्य आहे आणि खरं असं वाटतंय की एक संगम आपल्याला बघायला भेटतंय आणि ते खूपच कधी कधी भेटायला त्याला वेळ मिळत नाही कधी कधी. असे डॉक्टर सतीश देव पुजारी सर, मॅन ऑफ creation, innovations, all the technical things, whatever can be done at a practical level. And Dr. Mahesh Mohite sir, who started from the rural, peripheral rural settings, and he has just gone beyond establishing the intensive care in peripheral area of the Raigad. तर असं आपलं एक संगम मला भेटतंय आणि कदाचित त्या संगमला मिळणारे अजून त्रिवेणी संगम डॉक्टर जी व्ही बसवराजा सर, who is I can say मायटोकॉन्ड्रिया, आणि लास्ट गेल्या 2 वर्षी ते आपले CIPचे सेक्रेटरी होते आणि त्यांचंही आपल्याला ह्याच्यामध्ये ऐकायला मिळणार. And so we will be getting the knowledge from this Triveni Sangam of Dr. Satish Tiovachari sir, Dr. Mohite sir, as well as Dr. Basavaraja sir, if he managed to stay with us. Otherwise, he is a very busy person. And with that, and it all is a number. All the ABGs are totally mathematics and all numbers, and it is all of the. And I think so. In today's scenario, intensive care without ABG doesn't exist. It is a backbone of the intensive care, and probably reading that, interpreting, and calculations, and all this number mathematics to coming to the medicine. That is the most, and I think so. These both stalwart speakers will solve those calculations and how to get at the practical at a stretch of a hand. With that will be clear from this session. Hope so. Wish you each one happy learning. Thank you very much, Jay.
Our chief guest Basavaraja sir to give his blessings to this important session. Welcome, sir.
Thank you, Jay Kumar Bandarkar sir. Respected our president of Maha IAP, Dr. Hemant Gangulia sir, Secretary General of Maha IAP, Dr. Amul Pawar, the chief scientific convener of Maha IAP, Dr. Jay Kumar Bandarkar sir. Of course, my respected and the most dedicated person for the critical care, none other than Dr. Satish Devpujari sir, our past founder chairperson of IAP Intensive Care Chapter, and the present intensive care chairperson, none other than my close friend, and we almost 1.5 years we did all the programs of central IAP together. That is our Mahesh Mohite ji. And he has taken in the intensive care chapter to the greater heights during his tenure, and I'm sure still it is going to be there. And of course, our Samir Sadavate ji, so my close friend, and Renu madam, Dr. Neha, Dr. Mina Sheikh, our executive board member, and also the scientific chairperson of our IAP intensive care chapter at the national level. Just we concluded it in Jaipur. He's done a wonderful job. and is doing a great job even in Goa, our national intensive care chapters in CME also. And of course, our executive board member Bela Verma Madam, Narendra Nani Vadekar, and all other seniors of Maha AP. This is in a program which is in a conceptually very innovative way. And the moment we talk about ABG, we talk about in a one name across the world, not only in India, across the world, that is none other than Dr. Satish Devpujari sir, with a lot of innovation and lot of things. Sir has taken not only the ABG, all the innovation. You talk about ventilation, you talk about anything innovation during the COVID time. Sir came out with a novel idea of ventilation. This is something which is unique. So Satish Devpujari sir is going to give us a feast today with the along with Dr. Mahesh Moite, and it's going to be moderated by Dr. Samir Sadawate. Of course, Vishram Buche sir is there to add when as and when it is required. Sir is always there when there is Satish sir is there. So I'm sure without wasting much time, I'll take this opportunity to declare this program is open. And thank you very much for inviting. I am eager to listen to Satish Devpujari sir and Mahesh ji to learn from them. Thank you. Thank you all.
Thank you,
Welcome,
Mr.
Dr. Vishram. Welcome, Dr. Vishram, sir.
Shram Buche sir, welcome. I now hand over our further proceeding to our Samir sir for start the program.
Hello, welcome everyone. Good evening. Hello, am I audible?
Yes,
Yes,
Samir.
please go ahead.
Yes,
Okay,
Samir.
great. So let's see first about, we'll talk about what is Maha subspecialty. This is a chapter what we started from Maha IAP. Like Maha IAP, if you see, if you open on the YouTube Maha IAP channel, in last 5 months, we are almost around 190 programs so far. And every program is as such is a hit, but we give special characters to this Maha IAP subspecialty. So why this one? It is like a CME come talk where we call the expertise across India on particular subjects. So it's a very narrow subject and we talk about broadly about that. So now this time we thought to take something related to the blood, but as such a blood is such a big thing. And say like for ICU, whether you work in the respirology, whether you work in the nephrology, whether you work in the general pediatrics, you need something unique for everything. Like suppose in last 5 months, we have done sessions on cardiology, we have done sessions on ENT, then on the endocrine. So we thought something X-ray. Yeah, so something now is this one to be done due. So we thought the names of ABG, yes. So Dr. Jaikumar Bhandakar is the mastermind of this one. He comes with some theme. So, but for us, it was very difficult to get because we have 2 people who are very giant, particularly for the ABG. I will say first about Dr. Devpujari first, and then with Dr. Mahesh Moite about this part. So imagine, can you imagine in 1992, first time in the history of India, the first conference only on the ABG, which was done by Satish Devpujari sir. So it was almost like a 30 years from now. So it's the father for the ABG for the India, I can say is Dr. Satish Devpujari sir. Is a professor emeritus, not only for the medical part, but also in the engineering college. So his knowledge, as already mentioned by Ganguly sir and Jaikumar sir, that innovations done by him, there are so many. Like what we talked just now about Dr. Gatinoni, he has maximum number of the research papers, maximum number of the medical pediatric apps actually comes from the Dr. Satish Devpujari. So if you put the name of Dr. Satish Pujari, you will see a lot of things, innovations. Recently, he made the innovation on the Satish, which we know hundreds of the ventilators he and his team has donated in the COVID pandemic, which has saved the thousands of lives. So that's Dr. Satish Devpujari sir, who is from Nagpur. And also we have Dr. Mahesh Moite sir. He is also a very good and pioneer for the pediatric intensive care part, particularly for the rural area, as mentioned. He recently got the Lifetime Achievement Award also from the Maharashtra IAP for working in the rural area and making pioneer at the level 3 and level 4 of the types of cases handling at his peripheral areas. He is currently he is currently a chairperson for the intensive care chapter of the IAP and also work as a senior consultant in the Wadia Jai Jerabai Children Hospital in Mumbai. So welcome to both of our teachers today, Dr. Satish Devpuje sir and Dr. Mahesh Moite sir. And with all permission from everybody of you, and thanks Dr. Basavaraja sir for coming and giving us valuable opinion and tips. So let's start with Dr. Mahesh Moite, and everything to you, Dr. Mahesh sir.
Thank you very
Let's
much.
start your training.
Thank you very much, Maharashtra IIP, for giving this opportunity, especially to speak alongside Dr. Devpujari sir, who has been our father figure. We have learned so much from him over the last 30 years. And as Samir said, 1992, and not to forget, he hosted the first National Pediatric Critical Care Conference even before that. So he has many accolades to it credit. Turning to I'll start sharing my slides. Am I audible?
Yes, sir.
Yes.
Fine. So coming to today's topic, the arterial blood gases. Now, this is one topic which is taken as a intensive care personnel's domain, but which is actually not so, because the whole name starts with arterial blood gas. That means you have to take an arterial prick. But is it really mandatory to take an arterial prick? Perhaps one can get almost equal information from venous prick as well, provided you have a pulse oximeter connected to the patient. So only difference between arterial and venous is basically a PO2 in case of arterial, or saturation in case of arterial, which will be quite higher as compared to venous. And there will be little bit difference between the CO2 levels of the two, wherein CO2 in the venous blood will be slightly higher, something like 45, 46 as compared to arterial blood. Rest of the parameters are almost same. I'm going to tell you on the arterial blood gases, but mind you, in your clinical practice, you can do venous blood gas as well, understanding that the PaO2 will be relatively low or much low. Now, when you talk about ABG, it's not just numbers. ABG is a reflection of various metabolic and respiratory processes going on in the body and the ultimate effect of them at the time of collection of the sample. So there may be multiple process and the end effect, sum total of that is reflected in the ABG report at that point of time. So evaluation or meaning of the report, the ABG always comes after knowing the clinical condition and other relevant biochemical parameters of the patient. You can't be provided, ye ABG le lo aur bolo mara ka kya hai, which is very wrong. You need to know the whole history, the clinical examination, the other biochemical numbers on the background. ABG will tell you what probably is happening inside the patient, and you can take a proper action following that. There are not merely numbers. Treat the underlying disease and not the ABG numbers. So we are not treating the ABG. From the ABG, we get the information of the underlying arterio kind of the acid base and electrolyte imbalances, and then we take an appropriate decision to correct them. Now, there are two components in the ABG. I'm coming directly to the point. I won't be giving much preambles in that, because that will be wasting time. ABG itself, as Dr. Samir just now said, Dr. Devpujari hosted a two-day full-day conference on ABG, so you can understand the extent of it. But I'm going to give you clear kind of a stepwise approach to the reading of ABG. So there are two components when we look at a kind of a arterial ABG, the arterial blood gas analysis, or the blood gas component. There is a respiratory component, which in ABG is represented and reflected by the PaCO2 number and the pH coming out of it, and a metabolic component, which is represented by the hydrogen ion, bicarb ion, and in the ABG report, it is reflected by probably bicarb and the pH. Now, we all of us know the Henderson-Hasselbalch equation, which is a method to sort of take the oxygen into the tissue, take the oxygen into the tissue, push out the CO2 through the lungs outside, and that goes through this equation where water molecule combines with CO2, and that will form, 1 minute. That will form bicarb, the carbonic acid, and that later on is dissipated again into H and H plus HCO3, that is bicarb molecule. This is H plus and this is HCO3 minus. And this is carried away through carbonic anhydrase enzyme, which is available everywhere in all metabolating tissues. pH is inversely proportional to H ion concentration. So H ion concentration goes down, the pH will increase, the pH will increase, and vice versa. Now, when we look at the metabolic kind of a parameter, we are looking at two parts, the H ion concentration and the bicarb concentration inside the body. Now, H ion is increased by, which we ultimately call it as acidemia. When HIN increases, that will lead to acidemia or acidosis. Somebody want to try? Okay. So addition of HIN, which will be seen in cases of toxins, poisons, medications, salicylate, etc. There may be excess production inside the body in disease condition like inborn error of metabolism, diabetic ketoacidosis, lactates in hypoxia, or there could be non-excretion of HINs as in case of chronic renal failure, even acute renal shutdown. So this is how the HIN will be added to the body, which will lead to acidemia, metabolic acidemia. Vice versa, when there is excess loss, increase bicarb in the body, now this can happen in case this will be leading to alkalemia, which can happen through again addition through few poisons and toxins, or there may be retention of bicarbs by the kidney in cases of contraction alkalosis. So there is dehydration hypovolemia that can give rise to contraction alkalosis. Bicarb and this loss, this increased bicarb will cause alkalemia, and loss of bicarb will be seen in case of renal tubular acidosis or through GI in case of gastroenteritis. Now, coming to the respiratory component. So, as I said, the somebody can take up this. There are people waiting in the waiting room. Somebody can take it.
Because sir, the
Yeah.
Zoom
It is full now. We have to go through YouTube now.
They have to go to the YouTube.
Sir, I'm adding the address. I'm adding the message. Please continue. I'm taking care.
And Pallavi madam, please put the message in YouTube channel also. Please.
Yeah,
put
I'm
the
doing
message.
that, sir. I'm doing that.
Yes.
Okay, okay. So metabolic component, as I said, is related to HIN and bicarb combination. HIN bicarb concentration either increase or decrease in them will lead to metabolic acidosis and alkalosis. Now coming to respiratory component, which is represented by PaCO2 concentration. So increase in the PaCO2 will lead to acidemia. PaCO2, as I said, CO2 with bicarb with water molecule will convert to carbonic acid and will give rise to HINs. So that will give to acidemia. Now this can be seen in either airway obstructions, like upper airway obstruction or small airway obstruction. We see this in asthma and bronchiolitis. Upper airway obstruction may be seen in case of any laryngeal obstructions or tracheal obstruction. Now this also can happen due to central hypoventilation or peripheral. So if you have encephalitis or you have knocked down the patient with paralysis, that can happen, or a peripheral where there could be a diaphragmatic palsy or muscular paralysis. Now, there can be rare cases of excess production in hypercatabolic state or a high carbohydrate diet, which can also lead to CO2 excess production, and in all, they will lead to acidemia. When there is PaCO2 decrease, which can be because of the hyperventilation, as in case of encephalitis, again hyperventilation, or it can be functional in case of adolescent, where there is loss of CO2, washout of CO2, which will lead to alkalemia, and in a pathological state, decreased CO2 can also be due to tissue death or a brain death, where brain or the tissue is no more creating CO2, so that CO2 may go down. So I have discussed two parts: metabolic component represented by HIN and bicarb, and respiratory component by CO2, and up and down of them. So CO2 up will cause acidosis, acidemia, CO2 down will cause alkalemia, and I told you about the metabolic component. Now coming to next step, the conventional ABG has measured parameters which are measured as pH, PaCO2 and PaO2. These are directly measured, and bicarb is calculated parameter from pH and PaCO2. The most of the machine available in the peripheral labs are having this. The newer machines, they may be even measuring the bicarbs and displaying the numbers directly in your report. But majority machines which are used in the periphery, they are having these figures measured and bicarb invariably calculated. That's the reason we take these figures only into consideration while interpreting an ABG. I'm sorry again. This is really making too much. I'm sorry, this is
sir.
Madam, it's again disturbing me so much in this people waiting in this. Can you please, it's opened up, that window is opened up. Shit. And we're not fighting the cursor now. Yeah, okay, I'm there, fine. So there are common terminologies usually used interchangeably, but they are not so. Acidemia, alkalemia versus acidosis and alkalosis. So when we talk about acidosis, it's an ongoing process and it's not the final effect. Acidemia is a final effect. As I said, in the given patient, there can be acidosis and alkalosis both going together, and the predominant component will lead to a final component, which can be acidemia and alkalemia. To remember this, you can easily kind of correlate this with anemia, means a fixed number of hemoglobin which is lower than normal, or uremia, which is a fixed number of urea which may be above or below, or which is above the normal. So take this. These are the things. So when we talk, call it as acidemia or alkalemia on a ABG report, because that's the end effect of final total sum of the multiple processes going on in a given critical patient. Now, what are the normal values? It's important for calculation. Now here we are going to calculate the numbers. So we need to know the normal value. When it comes to pH, normal range is 7.35 to 7.45, but for calculation purpose, we take it as 7.4. So if it is 7.39, then it is acidemia. If it is 7.41, it is as alkalemia. Anything above that will go in the same direction. For a PaCO2, normal number is 35 to 45, but 40 is taken as a middle number. Anything below is alkalemia, it will cause. Anything above will cause acidemia. Bicarb, in a pediatric agent, we take 24 as a mid number, and neonate we take slightly less, 18 to 20 as a middle number. Now, reports. We need to understand, we need to check whether this report is valid or not, whether there is any technical fault or machine problem or reporting problem. It can be easily checked by the simple formula as H ion is equal to 24 into PaCO2 divided by bicarb shown in your ABG. Now, what is this H ion concentration? There are clear-cut standard charts available, which are going to show you next slide. And there you will get what is the H ion concentration at a given pH. So fill up that H ion number, because you know the pH on the ABG, fill up that number and calculate. And so for example, 7.4 at 7.4 normal pH, you have got 40, H ion number is 40. So 40 is equal to 24, PaCO2 normal is 40, bicarb is 24. So that becomes 40 equal to 40, right? So this, you have to fill up your number here, and if matches, then you proceed further, because then the ABG is valid. So this is a chart which I was mentioning about. At this pH, you will have this number of H ion. At 7.4, you have got 40. At 8, you have got 10. So put these numbers in that equation, and you will be able to judge whether the report is valid or right or not. Now, there are some fallacies in the collection. If there is excess heparin taken, which can lead to acidemia. Time for collection. You need to ideally analyze within 20 minutes. If it is going to take longer time, then store or transport the sample on ice so as to avoid any discrepancies in the report. Ideal method, many times when you take a prick, the child is crying a lot, he hyperventilates, and you can get false respiratory alkalosis, because with hyperventilation, he washes out CO2 and the pH may drop. So ideally, if you want a very accurate method, you ideally should be putting an arterial line or a venous line, and that's the time you collect, so that patient is sedated, and collect it when the patient is sedated or sleeping, so that you can get an exact report of the ABG or a BBG. Now, coming to the analysis of the ABG report. What are the steps? First step, as I said, there is slight difference between the neonatal and pediatric numbers, especially in case of pH and the bicarb. So know whether it is a neonatal pH, neonatal ABG, or a pediatric ABG. So accordingly, you know the normal number. So in case of pediatric, 7.4, CO2 40, and bicarb 24. And here it may be 7.35, CO2 40, and bicarb maybe 18 to 20. So that is important to know what ABG you are checking. Step 2, find out whether you are in acidemia or alkalemia. If the pH is less than 7.4, it is acidemia. If it is more than 7.4, it is alkalemia. Then look at the CO2. As I said, CO2 is a measured parameter, pH is a measured parameter, so we are only interpreting the measured parameter. Now, from the given CO2, is the pH deviation explained by PaCO2? So suppose I am having pH of 7.3 and my CO2 is 50. As I said, as the CO2 goes up, H ion will build up through the Henderson-Hasselbalch equation. So this CO2 explains the pH, which is going down, which will cause acidemia. And so here it is respiratory acidemia. So if pH is explained by CO2 change, it is primarily respiratory disorder. If pH is not explained by CO2, it is a metabolic disorder. This is basic sacrosanct statement in your analysis. So to understand it slightly better, at a standard stable bicarb, look at the pH and CO2. If the CO2 drops, pH will come up. If the CO2 increases, pH will go down. And here the pH is explained by the CO2 movement. So this is primarily respiratory problem. So in a previous case, this is washout of CO2 giving rise to increased pH. This is respiratory alkalemia. And in this case, PO2 is up. So collection or retention of CO2 giving rise to drop in pH. So this is respiratory acidemia. Now, how does bicarb, which is measure of the metabolic activities in this? So bicarb goes in the same direction of pH. So increase in the bicarb will cause increase in the pH. So look at here. Here there is a drop in the CO2 which cannot explain increase in the pH. So obviously the change in the pH is caused by the bicarb. So this is metabolic alkalemia, increased bicarb causing increased pH. Vis-a-vis drop in the bicarb causing drop in the pH. So this is metabolic acidemia. Here again, what you will be seeing in the report, CO2 is high. But what is supposed to cause if the CO2 is high? I'm sorry, don't look at the CO2, you're looking at only bicarb. So bicarb is going down, CO2 is going down. So that will be metabolic acidemia. Now, correlation of the pH changes. Every primary, when we look at the compensation subsequently, this particular formula will be helpful to know how much change a CO2 can make to the pH and how much change a bicarb can make to a pH. So every primary PaCO2 change of 10 leads to pH change of 0.08. So as I said, normal pH is CO2 is 40 and pH is 7.4. So increase in the CO2 to 50 should ideally cause drop of the pH by 0.08. That means you will get a pH ideally 7.32. Now, similarly, every primary increase change in the bicarb of 10 will make a change of pH by 0.15. Okay. So suppose bicarb instead of 24 goes to say 34, then how much pH will change? It will change by 0.15. So it will become 7.55. It will increase in the same direction, right? So what is the importance of this? Suppose you are not getting that expected expected pH correlating with CO2, you assume that the extra change that is made or less change that is made in the pH is caused by simultaneously having additional mechanism. So in a CO2, it is a respiratory pathology. There may be add-on metabolic compensation or metabolic pathology, which is not allowing the pH to respond in this equation format. I hope I am not making it very complicated here. If pH has changed more or less than expected, it is contributed by other component and it suggests mixed acid-base disorder. Step 4. Is it a compensatory disorder? Now, why compensation? Because body, whenever there is any abnormality or any challenge to the body has enough reserves to counter that challenge and maintain the homeostatic mechanism inside. So there is a respiratory pathology causing acidosis. Body will try to retain bicarbs from the kidney to counter that acidosis. So the kidneys will start making compensation. If there is a metabolic pathology, mechanical kind of a metabolic acidosis, it will stimulate the brainstem to cause excess hyperventilation. CO2 will wash out to create alkalosis. So these kind of a compensatory mechanisms are hallmark of the body's homeostatic mechanism. Now, how does the compensation happen in respiratory disorder? In a primary respiratory disorder, metabolic compensatory mechanisms come into play. So obviously, if there is a respiratory abnormality, metabolic compensation will happen. In an acute compensation by body buffers, hemoglobin, plasma protein, etc., they play very little part in the compensation. And renal compensation, which is very important, usually occurs after 24 to 72 hours after primary respiratory disorder. So metabolic compensation is different for acute respiratory condition and chronic respiratory condition. How does it happen? In an acute respiratory condition, every 10 change in the CO2 will lead to 1 change in the bicarb. So increase by 10. So CO2 becomes 10, that is 50. Then bicarb will compensate by making only 1 change, that's 24 immediately. And in the chronic, after say 24 or 48 hours, when the kidney compensation starts, then you have more compensation by bicarb retention from kidney. So in a chronic condition, 10 change in the CO2 will lead to increase by, so 10 increase bicarb will cause 3 to 4 increase. So 10 increase of CO2 will cause 3 to 4 change in the bicarb, and also same thing in the lower direction as well. What about the respiratory compensation? In a primary metabolic disorder, you will see a respiratory compensation where the changing pH immediately works on the respiratory center to control respiratory rate appropriately, and compensation is same for acute and chronic metabolic condition. There is nothing like acute and chronic metabolic compensation in case of respiratory. In case of metabolic disorder, you have immediate equal compensation from the respiratory system. So metabolic acidosis, whether it is acidemia or alkalemia, for 1 change in bicarb, CO2 changes by 1 to 1.5 in acute or chronic. So what I mean to say, there is metabolic acidemia where bicarb drops by 10, the CO2 will drop by about 15 as a compensatory, as a complete compensation or near complete compensation, and vice versa in other direction. There are basic rules of compensation. There is never overcompensation. There is never complete compensation. So if you see that kind of a thing, imagine there is additional mechanism and not a primary standalone pathology. As far as what CO2 you expect in case of metabolic disorder, so metabolic acidosis, which will cause decrease in the bicarb, what expected CO2? This is one more formula. PaCO2 in a metabolic disorder is equal to bicarb into 1.5 plus 8 plus minus 2. If PaCO2 is less than expected, there is additional respiratory alkalosis, hyperventilating too much. If PaCO2 is more than expected, then there is additional respiratory acidosis. So slightly complicated looking, I understand, but I'm trying to make it as simplistic as possible. There are multiple mathematical formulas coming in this, but as an intensivist or even as a basic pediatrician, it's not very difficult to remember if you do it reasonably regularly. Is there a mixed disorder? Is a rule 5. So next thing you're going to do, is there a mixed disorder beyond compensation? So if pH, PaCO2 and bicarb relation is not explained by the previous calculation, you assume there is a mixed disorder. What I mean to say mixed disorder, say you have a child who had asthma, which is progressing further. So initially asthma will cause CO2 retention and he will develop respiratory acidosis. Over the time, increasing acidosis itself will cause decreased tissue hypoperfusion and a metabolic acidosis will mount in. This is mixed disorder. You may have a hypersepsis, which can have hyperventilation initially and going to sepsis. So this is the respiratory alkalosis initially, maybe add on metabolic acidosis. So this is slightly complicated, but to complete the topic, I have to take those into my talk. So PaCO2 and bicarb moving in the same direction is usually a single metabolic disorder. If they move in a different direction, either moving towards each other. When I say moving in the same direction means both are moving up or both are moving down, you have a single disorder. If they move towards each other or they go away from each other, then you think there is likely to be a mixed disorder. What next? Once you know what is the cause of this mixed disorder, you know what is the ABG. In a metabolic acidosis, you need to know the anion gap. What is this anion gap? We have been hearing about this from the undergraduate days. So in the body, there is an electroneutrality. There are equal number of positive ions and negative ions, intracellular as well as extracellular. When we collect the sample for ABG, we are essentially taking a sample from plasma, which is extracellular, and there are equal number of positive ions, which are called as cations, and there are equal number of positive negative ions, which are called as anions. Now, these are the cations, and these are the anions. But we have fixed number of anions available for measurement. Like on positive side, we have got sodium, or negative side, we have got bicarb and chloride. You may add potassium to this. But there are unmeasurable cations and unmeasurable anions, and this gap is what called as anion gap. Unmeasurable anions minus unmeasurable cations is the anion gap. How does it help us in understanding or coming to some conclusion in case of metabolic acidosis. So for this calculation, we essentially take into consideration these molecules, and normal anion gap should be about 12. If you take potassium into consideration, it will be about 15. Now, there are conditions in which body loses bicarb. Only two conditions, either coming from renal tubular disorders like RTA or gastroenteritis, wherein you lose bicarb, but immediately, suppose it is gastroenteritis, bicarb drops, the kidney start functioning to retain the chloride will increase. In a renal tubular acidosis, similarly, if you lose bicarb, then this chloride will be retained from the GI system. So what ultimately the number of measurable anions remain the same, hence the anion gap remains to be the same, though because of bicarb, there is metabolic acidosis coming in this patient. So this is normal anion gap metabolic acidosis, which you see in a GI gastroenteritis, diarrheas, and renal tubular acidosis like condition or polyuric condition. Now take a condition in which there is extra anions are increased. You have more negative ions being created. Why it happens? Actually, it's not more negative. Go to the previous slide. This is loss of bicarb. So suppose metabolic acidosis due to certain condition where H ion is added, citric or diabetic ketoacidosis. You take CRF, or you take maybe a poisoning where some H ions are added, they will hinder or they kind of neutralize bicarb. So bicarb is lost, and now there is nothing to compensate, and you have increased anion gap metabolic acidosis. So you've got high anion gap metabolic acidosis condition, and these are the condition in which. So simple approach, metabolic acidosis has got normal anion gap acidosis, which is seen in bicarb loss of GI or bicarb loss of kidney, where the chloride is written from the other end, either kidneys or GI. Increased anion gap metabolic acidosis, it can be because of toxic ingestion, something like salicylates. It can be overproduction of endogenous acids, as in case of lactic acid, your septic shocks or shock-like condition, hypoxia. It could be ketoacidosis, as in case of diabetic ketoacidosis, or IM-like condition where acids are added. And third condition where you got excess anion gap is decreased excretion, as in cases of renal failure. So this is a very simple chart to analyze further. Is there any further? So in case of anion gap, increased anion gap metabolic acidosis is simple mnemonic given in Tobias book, which is mud piles: methanol, uremia, decay, poisoning, IM, INH, infections, lactate, ethanol. These are all conditions which will be, in case of metabolic acidosis, will lead to high anion gap metabolic acidosis. There's one more concept called as delta anion gap. This is usually used for high anion gap metabolic acidosis. Basic concept: you added increased H ions will neutralize bicarb, thus bicarb levels will drop. This will also increase anion gap, which is high anion gap metabolic acidosis, as I told you. Now this increased anion gap, also called delta anion gap, should be equal to the drop that you see in bicarb, because you're adding certain H ion, bicarb is dropped. So that anion gap should be proportional. This bicarb drop should be proportional to the anion gap which is increased. So delta anion gap is 24 minus bicarb. If it is not equal, is suggest additional mechanisms. I'm making slightly complicated. Bear with me, last few slides. Effect of albumin level. There are certain things which may further confound the reports. Anion gap changes with level of albumin as well. Apart from bicarb and chloride, albumin and phosphate constitutes major anions in the body. With hypoalbuminemia, total anion gap may fallaciously look less. Now these bicarbs and phosphate, they are also part of the anions. So if there is decrease in the albumin levels, obviously you will see fallaciously increased anion gap. That can be corrected as the observed anion gap plus 2.5 into 4 minus albumin. So normally you expect albumin to be 4. If it is 4, then 2.5 into 4 is 0. I mean, this 4 minus 4 is 0. So there is no addition, whatever anion gap is right. So suppose this is 3, then it's 2.5 added to the anion gap. 2.5 into 4 minus, that is 1. So 2.5 added to this. That's what I meant to say. You have to have some correction level for the albumin. This factor to be added to calculate anion gap from ABGs and electrolytes. There are also one concept called as osmolar gap. I won't take that. We'll straight away move to the summary, friends. I hope I have not made it very toxic. You have to read the patient clinically first. These are all numbers which are shown. Without the clinical information, without the proper history, without you are having some kind of a good conclusion made out of that, you should not move to the ABG. When you are asking for any investigation, not only ABG, you are asking for any investigation, first think what do you expect from it. It cannot be a shocker. If it is shocker, then either you're wrong in your conclusion, your clinical analysis, or you may be having something really sinister underneath. So read the patient clinically first, think what you expect from the ABG, correlate the two for a final conclusion. I'm sure it will help you. At the same time, lots of quick calculations are involved. I've shown you almost 7 or 8 basic formula to interpret this. I'm sure that's a huge mathematical revisiting. Sorry for taking you to the mathematics class again, but without that, the ABG cannot be interpreted, friends. Thank you very much for your patient hearing.
Okay, thanks, Dr. Moitis sir. It was a very nice talk as usual. What you do always in your talking. Rather than wasting our time more, we'll directly jump and we'll ask Dr. Depujay sir. Are you there? Please start your slides, sir. In your talking. Rather than wasting our time more, we'll directly jump and we'll ask Dr. Depujay sir. Are you there? Yes, sir. You are unmute. We need to unmute you, sir. Depujay sir, please unmute yourself first. I don't know. Hello, Dr.
Pallavi madam, please.
Oh, केलंय
Please
sir.
unmute.
Permission दिली आहे.
So sorry.
I'm making him co-host.
Yes.
Just a minute, sir.
Hello.
Hello.
Depujay sir, you are audible now. Please start your own screen.
I need the.
Yes. You will get the permission, sir. Madam, Pallavi madam केलंय? Hello.
हो सर झाले permission.
Yes, sir, you can share.
Okay. Can you see my slides?
No,
Not
no,
yet.
sir. Madam, guide kara, please. Pallavi madam.
हो सर मी नाव बदलत होते सरांचं.
Yes.
हॅलो पुजारी सर, देव पुजारी सर, तुम्ही स्लाइड ओपन केली आहे?
Yeah.
ओके.
Yes.
It is visible now, sir. फक्त प्रेझेंटेशन ऑन करा.
Right. Can you see the presentation now?
Yes, sir. It is visible.
Okay.
Thank you, sir.
Right. That was an excellent presentation by Mahesh. So thank you, Maha IP, for this chance on a topic on ABG. So without going through much of the formalities, I'm going to straight jump on how do you analyze blood gas. Am I audible to all of you?
Yes, you are audible, but if slightly bigger voice is better. I think so.
Okay. Is it okay now?
Yes, sir.
Yes, sir.
Okay.
Perfect.
Now, I'm going to take a slightly different route as to how you should analyze ABG. In fact, by taking you through the app, and this will Can you see my screen now?
Yes, sir. It is visible.
Right. Now, you know what? Let us take a slightly different route. We'll go through the entire process of how do you analyze the blood gas. Now, the two of the apps that I'm going to show you is used by more than 1 lakh of people across the globe in trying to analyze the ABG reports. I would suggest the simplest thing would be when you get an ABG report, what you see, a typical ABG would analyze pH, we'll look for PO2, we'll look for PCO2. bicarb is not estimated by ABG machine. It is calculated by PCO2 and pH. Now, if you get a report, enter the pH. You see you see the green zone, correct?
Yes, sir.
As you go towards this becomes red. So this is an acidic pH. Okay. Now, enter CO2. If the pH is acidic and CO2 is less, you have metabolic acidosis. Can you see the bicarbonate there? It's 12.
Yes, 12, 12.
Now I'll show you a very interesting thing. I'm moving CO2 and see the way bicarb moves. I'll move it again.
Yes.
Now, you must have realized that the least important thing in ABG is bicarb. See this. If I move CO2, bicarb moves. In fact, bicarb is not a prime determinant of pH. I will explain you all of these things in the ABG book. So ABG book was the world's first book on ABG, and this was inaugurated in Royal College London about 8 years back. So we'll go through the ABG book app. At the moment, if you get the ABG report, my request would be enter pH, enter CO2, and you get the diagnosis. Now let's see if the pH is, say, 7.30, and bicarb is 29, you have simple metabolic acidosis. Okay. Now, on the same pH of 7.30, Mahesh very clearly showed us the normal values. So he showed us that the normal value of CO2 is 40, and this CO2 at this moment is less than 40. So if you have low CO2 and acidic pH, you are dealing with metabolic acidosis. If I increase the CO2, you are talking of respiratory acidosis. Is this clear? Now, don't try and move on this app the bicarb level. But what I would suggest is the level of bicarb shown in this app is 20. And if you're in the ABG report, you don't see as 20, then the only conclusion is your ABG report is wrong. I hope this is clear. I'll again go through the steps.
Yes, sir.
See the green zone.
Yes, sir.
This is a normal zone for pH. Okay.
Yes, sir.
Now I turn it towards acidic side. It becomes red.
Yes.
Now this zone is acidic pH.
Yes.
There are two options. With acidic pH, you could have low CO2. You are talking of metabolic acidosis. The other option is you have high CO2 and you are talking of respiratory acidosis. Okay.
Yes.
Now, let's go on to the other side. The pH is alkaline here, so 7.49. Again, alkaline pH could be of respiratory origin, could be of metabolic origin. If I lower this CO2, say to 16, you have respiratory alkalosis. If I lower this CO2 to less than normal, you have respiratory alkalosis. Common cause, if I could engross you in my presentation and you're focused on it, and suddenly you see some suspicious object crawling on your feet, you'll hyperventilate. The moment you hyperventilate, you throw out CO2. Remember, please remember one thing. For doctors, CO2 is an acid. For a chemistry man, CO2 is a gas. So if you have more CO2, you have acidosis. If you have less CO2, you have alkalosis. Now see here, CO2 is 27, less than normal. You have respiratory alkalosis. Now, if I increase the CO2 and if I make the pH acidic, you're talking of respiratory acidosis. I will again summarize. We will get into the details of ABG. I mean, I would be happy to go on overnight, but at the moment, I would suggest please download these apps. They are free. They are the world's largest downloaded apps today. There's no country in the world which is not using these apps. And play with them and play with them. For years, ABG has been a class example of academic terrorism. People frightened us about ABG. With these apps, I would make it playable. One of the most important thing I'm showing you, as you can see here, pH remaining same, I'm moving my CO2 and see how the bicarb is moving. So bicarb has literally no way or help in diagnosing ABG. If you want to diagnose ABG, only you need two things, pH and PCO2. So if your pH is, say, 7.26, and if your PCO2 is, say, 26, you have a typical metabolic acidosis. pH acidic and low CO2 makes a typical metabolic acidosis. And this is what you get like in a patient of diabetic ketoacidosis or in renal failure or in patients with dehydration with lactic acidosis and things like this. Is this clear? So metabolic acidosis is pH in the acidic range and bicarbonate low. If you have acidosis with high CO2, you're talking of respiratory acidosis. Okay. If you come to the range on the alkalotic side, so 7.50 pH, and if your CO2 is high, this high CO2 is a compensation towards metabolic alkalosis. But alkaline pH with low CO2 makes it respiratory acidosis. With this, I will now close this app and take you through my presentation. So please download ABG book and complete ABG. As I've told you, these are free apps. I'm extremely thankful to the software help that I got. This is a very complex software. I have not patented these apps, but nobody could ever copy it to the extent that we have this app. And this is the world's only ABG app, which will give you a disease-specific diagnosis. It can tell you that you are dealing with RTA type 3, or it can tell you you have hyperaldosteronism. No such app exists across the globe. And if you use iWatch, I have an app on iWatch. This will be the world's first app on iWatch. This was inaugurated in John Hopkins about 6 years back. So we have apps on all platforms, on Android, iOS, and on iWatch. Now, this is a menu of today's discussion. This is the ABG book. So we have ABC of ABG, understanding pH and respiratory and metabolic disorders. We'll make the Henderson-Hasselbalch equation playable, acute and chronic relationships. Then these are ABG graphs, which are unique. There is no such dynamic across the globe, which will show you the ABG graphs, with which we will learn to play, and ABG tutor, and the information and algorithms used in this app. In this app, I have shown all the algorithms on which the app works. So there's nothing left or nothing hidden by me when I created these apps. Now, this is what is a relationship between pH and H ion concentration. You can see the relationship is inverse because simple pH is log of 1 upon H ion concentration. Obviously, if the H ion concentrations increase, the product will decrease. Is 1 upon H ion concentration. pH is log of 1 upon H ion concentration. And obviously, this simple thing can actually show you as to how they are related. If you see the video, you see the blue dot means you are in the alkaline zone. Green dot will mean normal zone, and red will mean acidic zone. And the relationship between pH and H ion concentration is inverse. I will show you that when we go through the book. Is this clear? So remember, pH is log of 1 upon H ion concentration. Forget about the numbers here. Please focus on this slide. Respiratory disorders are essentially because of CO2 abnormalities, and metabolic disorders are essentially because of bicarbonate abnormalities. And so remember this slide. This is something which you got to understand as to what it means to be a metabolic disorder and to have a respiratory disorder. I hope I have made it clear. Of course, someday, if you give me a chance, we will discuss on Stewart's hypothesis, and I'll take you through another journey on ABG. Now, we have always been frightened with this Henderson-Hasselbalch equation. So what I've done is, I've written the equation there, and I'm making it play for you. So you can see the equation being played, and you can see I've shown bicarb of 24 and CO2 of 40. And as I move these values, the equation of pH is equal to pK plus log 10 in the bracket of SCO3 minus divided by H2CO3 is not complex, mind you, is seriously not complex. When you go home, open the ABG book and play the equation. With this equation played, every value will change step by step. You can make it slow for you to understand, but please do this. And lakhs of people are using this to understand how the ABG works. And I would like our own friends to use it, because this app is created by our own software industry. And I'm obliged to them, as I've told you. So this is the equation that we always are afraid about. The most interesting thing is shown in this app. If you understand this, you'll understand ABG. what I'm trying to show is normal pH of 7.4 can be seen on thousands of combinations of bicarb and PaCO2. Like, I'm trying to move the bicarb. Say it is 49 here and CO2 is 81. pH is normal. On bicarb of 54 and PaCO2 of 90, pH is normal. On bicarb of 6 and PaCO2 of 100, pH is normal. If you can understand this, that pH is a normal ratio between acid and base. Normal pH does not rule out acid-base disturbance. So I'm showing you normal pH on various permutation and combinations of bicarbs and PaCO2. As I'm saying, please go home, download the app and play. That would give you a perfect understanding as to what I'm trying to show you by moving these various values. And this is what an understanding of ABG would be. Normal pH means a normal ratio between acid and base. Now, if you look at an ABG value in toto, you are talking about pH, you're talking about PaCO2, you're talking about PaO2. pH and PaCO2 will give you acid-base assessment. PaCO2 and PaO2 will give you respiratory assessment. Plus clinical evaluation will be your complete assessment. I hope it is clear. pH and PaCO2 talk of acid base. PaCO2 and PaO2 talk of respiratory component. Add to that clinical evaluation, and that is the complete assessment of ABG. Now, when you get an ABG report, you see a lot of things. Only 3 or 4 things need to be seen. But please, when you get an ABG sample, enter FiO2 is an extremely important thing. Without an FiO2 entered into the ABG report, without the entry of FiO2 into the ABG report is not worth it. Please enter FiO2 and remember what are the measured values in an ABG machine. ABG machine only measures pH, PaCO2 and PaO2. Remember, bicarb is not measured by machines, by ABG machines. And remember, you'll be surprised, bicarb is an electrolyte. Bicarb is an electrolyte. In US and other countries, it comes in an electrolyte panel, like your sodium, potassium, chloride. Bicarb is the same batch. So a lot of things could go wrong when you try and do all kinds of calculations on the bicarb that you get on an ABG report. In fact, one of the papers from AIMS did all kinds of calculations a few years back, depending on the bicarb that came out of the ABG report. And after I wrote to them that this is not correct because the ABG report bicarb is not a measured parameter. Of course, you can trust on it, but the limit to which you trust. So ABG report only needs, you need to focus on pH, CO2 and PaO2. Certain values are useful things. Forget about temperature corrections and things like this. Remember the calculated parameters. Please remember the pulse of the saturation that you get on ABG report. Saturation that you get on ABG report is calculated from the PaO2 value. Is calculated from the PaO2 values. So I'll show you how it is calculated. So if you open this ODC app, see when I move the values, like the saturation gets calculated, and that is how the ABG report calculates. Remember, please focus on content of oxygen. See, as I'm entering the content and increasing it, the content of oxygen in the blood, 100 ml of blood is increasing. So your saturation is worth nothing if you don't get the content of oxygen. And how do you get the content of oxygen? Hemoglobin. Please see here. Hemoglobin of elephant content is 13. Hemoglobin is 8. It is 9.58. Hemoglobin is 5. It is just 6. And the ideal content would be at least somewhere around, minimum should be 10 or 8. And remember, this is how you need to look at the pulse oximetric reading, or for that matter, the ABG report showing you the saturation. So it's important to look into this. One sec, I'll just. So when you get an ABG report, about 50% of things mentioned there are at most, if would be decent, would be useless. You just look to the most important things, and that is the 3 things that I've told you: pH, PaCO2, PaO2, and bicarb. So these are certain equations, and I will skip these. But this has been a terrifying equation, and we will make it simple. You'll be able to play with this equation. Remember, pH is equal to log of 1 upon HON concentration. You will be surprised every time we are taught that the HON concentration and pH are not linearly correlated. This statement is actually not correct. I will, maybe next meeting I'll show you how it is not correct, but that got my first entry to John Hopkins about 15 years back when I wrote to them the non-linear aspect of this relationship. But presently, just remember, pH is equal to log of 1 upon HON concentration, and that makes the relationship inverse. So the parameters for oxygen, the content of blood, saturation, A gradient, and ratios are all calculated, provided you have entered the FiO2 correct. And that is why with every ABG report, you must enter we will not talk of oxygen this time. We will skip it for the next lectures. We'll come to the acid-base status. But remember, a simple formula by saying 20 into 5 is 100. Now, what do I mean by this? Normally air contains about 20% oxygen. That is our FiO2. If you multiply this by 5, you get PaO2 normally, isn't it? That is when I'm talking to you, I'm inhaling 20% oxygen, and my PaO2 would be about 100. So 20 into 5 gives me a rough calculation of what to expect in terms of PaO2 depending on my FiO2. Suppose I'm inhaling 40% oxygen. My expected PaO2 would be 40 into 5. If I'm inhaling 30% oxygen, my expected PaO2 will be 30 into 5. So that's about 150. If it is not so, then there's a wide AA gradient, and there's a problem in taking oxygen from the alveoli into the blood. Is this clear? I will again say this. This is important to understand. When I'm inhaling air at this moment, I'm inhaling oxygen of about 20 to 25%. In my arterial blood, it is expected that my PaO2 would be 100. That is 20 into 5 will give you my expected PaO2. Imagine if I'm inhaling 40% oxygen, then 40%, 40 into 5 will be the expected PaO2. If I'm inhaling 100% oxygen, then my expected PaO2 should be 500. If it is not 500, if it is 200, then I have a serious problem of transferring oxygen from the alveolus to the arterial blood. So the essentials for blood gas report are these, and focus on these reports. Technical errors, Mesh had got into some of them, like heparin was one of them. Now, I want you to be the world's best analyzers for blood gas. And 5 steps for successful blood gas analysis would be these. And please only follow this way. So the first step would be, don't look at anything else but look at pH. Okay. pH less than 7.35 is acidemia. pH more than 7.45 is alkalemia. Is this clear? So look at the pH. Is this acidic or is this alkaline? That is your step 1. And I'm saying, when you take an ABG report, don't get into varieties of things which are shown there to sell the machine. They mean nothing to a clinician. Your approach should be simple. Step 1, look at the pH. Is it acidemic? Is it alkalemic? Second step, if the pH has changed, who has changed the pH? Is the second question you must ask. What is the question? If the pH has changed, who is the culprit who has changed the pH? There are only 2 fellows who can change the pH, CO2 and bicarbonate. If the CO2 changes pH, it changes pH in opposite direction. That is, increasing CO2 will decrease pH and vice versa. So, if CO2 has changed the pH will always change in opposite direction. I hope it is clear. If bicarbonates change the pH will change in the same direction. Low bicarbonate would lower pH. High bicarbonate will increase pH. So, किसी को चोर बोलने के पहले आपने वो चोर के कैरेक्टर्स को आइडेंटिफाई करना चाहिए. CO2 is one thief. If it changes pH, it will change the pH in opposite direction. Bicarbonate will change the pH in same direction. यदि ऐसा नहीं होता है तो ये चोरी इन्होंने नहीं की है. So I hope I have answered the question. Who is responsible for changing pH? Okay? And by now, your diagnosis is made. Simple. Acidemia. You have found out किसने change किया है ये pH. CO2 ने change किया है तो opposite direction में होगा. Bicarb ने change किया तो same direction में होगा. By now you made a diagnosis कि metabolic acidosis है कि respiratory acidosis. Metabolic alkalosis है कि respiratory alkalosis. In metabolic acidosis, metabolic means bicarb. So metabolic acidosis means bicarb यदि कम है तो pH भी कम रहेगा. In respiratory acidosis, यदि acidosis है and CO2 is the cause, तो CO2 हमेशा ज़्यादा रहेगा. So that is how by now your diagnosis is made. And this diagnosis will stand true in most situations. Now, in fact, I'm trying to show you. You may skip the slides because I think time would be a constraint. We'll take these lectures in details, but how the app was made through our understanding of Microsoft Excel and the wonderful graphics that evolve out of this. So, step 3, if there's a primary respiratory disturbance, is it acute or chronic? Is a question. If there's a primary respiratory disturbance, is it acute or chronic? If it is acute, then for every change of CO2 of 10, pH will change by 0.08. Remember, acute में pH में change बहुत ज़्यादा होगा for a given change in CO2 as compared to chronic, where the change will be only of 0.03. ये भी आपको याद रखने की जरूरत नहीं है. We'll come through it as to how it happens. Now, this is diagram with the video, which is a part of my ABG book, which show you CO2 green वाला देखो is 40, ये 50 पे गया, means there is acidosis. So ऊपर का box red है, focus on that box. And I have shown you acute respiratory acidosis में backup 25 हो गया, but the chronic है तो 28 है. अभी आप थोड़ा ध्यान रखो, it goes to 60. Right? Your acute, if it's acute respiratory acidosis, backup से 26 है. If it's chronic, it's gone to 32. Means now it is 70. The change in acute is much less as compared to chronic with 36. So as you start seeing reports, आपको वैसे ही पता चलेगा. यदि 70 CO2 है and backup थोड़ा ही बड़ा है, तो it is acute respiratory acidosis. मगर ज़्यादा बड़ा है, तो chronic respiratory. You don't have to remember the numbers. अभी जैसे हम नीचे जाएंगे, is this clear? See, I have made it clear. Red is acidic. ऊपर का box acidic. अभी देखिए, I am making the CO2 less. 20 हो गया. Acute में change बहुत कम हुआ है. सिर्फ 24 से 20 हो गया. Chronic में बहुत ज़्यादा हो गया. 16 हो गया है. अभी CO2 10 है. See the change. And go home and play with it. I tell you, there are people, like the fellow in Japan who was so certain with ABG. He wrote to me, Dr. Ubey, after playing with your ABG app, it is peanuts for me. So, sincere advice, play with the ABG book. And you could be the world's finest people to analyze ABG. Step 4, if the disturbance is metabolic, you need to know, is the compensation complete or it's not complete? And don't have to know the formulas very well. We will have some very simple things to come. Remember, compensation can never be complete. That means it can never bring the pH to absolute normal. And what is absolute normal? 7.40. So pH 7.40 पे कभी भी नहीं आ सकता है, except one, respiratory alkalosis is the only disorder which could have full compensation. There is no other disorder which could have a full compensation, meaning thereby that the pH would come to 7.40 can never ever happen. So the fifth most important step is clinical correlation. And believe me, this indeed is the most important step. I mean, I can explain anything on ABG to any clinical situation, depending on what the clinical state of the patient is. Please remember, bicarbs move pH in the same direction. CO2 moves pH in opposite direction. So this is about the mud piles for high anion gap. Change of CO2 of 10 will change pH. In acute situation by 0.08, in chronic by 0.03. ये भी मैं simple कर देता हूँ this way. So आप देखिए 3 looks like 3, 0.08 and 0.03. Interpretation of ABG by 4-step method of Dev-Sat. What is Dev-Sat? Dev Pujari Satish. So this is my method. Look for pH. Answer, who changed the pH? If respiratory, is it acute and chronic? If metabolic, is the compensation complete? And look for anion gap and go for clinical correlation. Remember, compensation is considered complete when the pH returns to normal range. Normal range, 7.35 to 7.45. But pH can never come to a dead normal value of 7.40. It can come to a normal range, and that could be kind of a complete compensation. Now there are certain, I mean, how much want you come? So there are limits of compensation. Like in metabolic acidosis, CO2 cannot go less than 10. So if you see a patient, say diabetic ketoacidosis, जिसका CO2 5 है, in that case is metabolic acidosis plus respiratory alkalosis. Similarly, metabolic alkalosis mein CO2 can go up to maximum 60. If somebody has CO2 of 70 and has metabolic alkalosis, he has metabolic alkalosis plus respiratory acidosis. In respiratory acidosis, bicarb can increase to maximum 35. And respiratory alkalosis, bicarb can be up to 15 and not less than that. So let's go through some cases. 16-year-old female with sudden onset of dyspnea, no cough or chest pain, vitals are normal, breathing at about 56 and anxious. This is reverse of these kind of things that you see. Poor fellows could hyperventilate because the whole thing is covered by a bag. So if I come to this case, sorry. So that was a patient who had respiratory alkalosis. pH was alkaline, CO2 was low. We'll come back to that if you, but it's a very simple thing to follow. Now this 6-year-old with increasing distress, look at the pH, 7.301, means acidic. Look at the CO2, 76 means बढ़ा है. CO2 बढ़ा है और pH कम हुआ है, means inverse relationship. Means CO2 is responsible for changing pH. PO2 is less, means there is hypoxemia. Now, we know for sure that this is definitely respiratory. Now, you don't have to touch an ABG report. देखिए, pH is 7.30, means बहुत कुछ कम नहीं हुआ है. From 7.4, it came down to 7.3. But CO2 has gone almost double. 40 का CO2 almost 80 हुआ है. Means though it has gone up so much, there is not much of a change in pH. Means this is chronic respiratory acidosis. आपको numbers देखने की जरूरत नहीं है. Common sense. CO2 का 40 का almost 80 हो गया, but pH has not changed much. Means chronic respiratory acidosis. And there's less of oxygen. The gradient is normal. This is due to hypoventilation. Again, I have an app for this. So get into this app. Okay. Change the FiO2. Say इसका FiO2, suppose 40 है. Find out what the PaO2 is. If it is less, आपको enter कर दीजिए. Enter the CO2 and see the AA gradient. This is one app which should be always used when you analyze an ABG report. But remember, I have been repeating this. Any ABG report without an FiO2 is not worth it. So you have to enter FiO2 on your ABG report and you get the gradients. It gets affected by RQ, respiratory equation. And if you are flying this patient through an helicopter, you can change the barometric pressure and correct your AA gradient accordingly. And I've given the information of this app that you can see. So please use this app. They're very, very useful things to do in any of our patients with ABG analysis. So this hypoxia is because of increasing CO2. 8-year-old asthmatic has been coughing for 3-4 days, and the ABG report is shown here. pH of 7.24 is acidemia. You see the acidic change too much. 7.40 से 7.2 आ गया है. Now PCO2 is 49. Means it has gone up, but not much. And PO2 is 68.3. Now see the bicarb. Bicarb is 20, means there's not much of a change in bicarb. So CO2 has gone up from 40 to 49, but bicarb is just about hardly any change. That means mostly this will be acute respiratory acidosis. I hope it is clear. pH is acidic. CO2 has gone up, means it is acute, means it is respiratory. And see, bicarb has not changed much, means it's an acute respiratory acidosis. With increase in bicarb, what should happen is that this should be a reflection. Just imagine the bicarb that is decreasing here. Do you think it is an element of metabolic acidosis? Anyone, do you think that the bicarb going down from 24 to 20 could be an element of respiratory acidosis? I'm just trying to confuse you. See the pH, 7.24 means the pH is acidic. See the CO2, 49 means it has gone up. Means this is respiratory acidosis. Is this clear? Now remember, when the CO2 goes up, bicarbs always go up. With the CO2 going up, bicarbs must go up. If it is not going up, in fact it's gone down here, means there's an additional metabolic acidosis. I will show you this and make you play with this. So let's go to this app. Okay, the pH was acidic. I forget the pH, but let's say 7.32. CO2 was something like, I think, 47. Okay, now, if this is true, see the bicarb that is shown as 26. This will be a typical patient with respiratory acidosis. But if it is a combined acidosis, the bicarb will be less than 26, and that is what was seen in that patient. So we'll just come back to this report. pH 7.24, CO2 around 50, that means respiratory acidemia. But bicarb is on lower side, means there's an element of metabolic acidosis. Otherwise, in a simple patient with respiratory acidosis, there's no reason for the bicarb to be on the lower side or lower than 24. So this patient, even if you don't calculate, would have a combined disorder. Patient also has hypoxemia and with a wide AA gradient. So there's a problem with diffusion of oxygen from the alveoli to the pulmonary capillaries. Now this 8-year-old diabetic, pH is 7.23, means acidemia. See the bicarb, much low, 9. So you know now that low bicarb, low pH means definitely metabolic acidosis. See the pH of 7.23 and see the CO2 value. That also is 23. Means the compensation is adequate. There's a simple formula. in metabolic acidosis. Simple formula in metabolic acidosis.
Sir, you can
Hello?
share again. Sir, you
Okay,
can
okay.
share
Yeah,
again.
yeah. Can you see?
Yes, sir. I can see your screen, but not the presentation.
Yeah, I see.
Yes, sir. Yes, it is visible, sir.
Yeah.
Thank you, sir.
Right. So this is typical DKA. Child with encephalopathy, pH 7.46, CO2 of 28, pH of 55.3. It shows pH of 7.46, means alkalemia. Correct?
Sir, please carry on. Hello?
Can you see now?
Yes, sir.
Yeah. Yeah, so this was respiratory alkalosis. Correct? pH 7.46, CO2 on the lower side. See the bicarb. Bicarb also is low. So this is a compensation that comes out of when it is respiratory alkalosis like this. And in respiratory alkalosis, kidneys would excrete bicarb. So there's a very interesting thing. In India, about maybe 1,000 years back, kings were knowing that in respiratory alkalosis, kidneys would excrete bicarb. Guess how? So if there's a war, the frontline warriors are the trumpet blowers. If they blow the trumpet very well, next day their urine will show phosphates and would show white precipitate. So it was checked. If the urine showed white precipitates, they were coming out of phosphate, means the first line warriors had blown their trumpet very well. So it was known then that in respiratory alkalosis, kidneys would excrete bicarbs. So these are certain things. I don't know whether you all have still the mindset to carry on with the ABG, or we could postpone it for some more session. Hello?
Sir, you continue right now. Continue, please, now.
Are you
Because it's
sure?
very
Okay.
interesting for our people who are still watching. Please continue.
Okay. So see this graph, which also has come out of the ABG. it shows you the relationship between CO2 and PaO2, okay, as we have ventilate. So you can see the inverse relationship between these two values. And it's like if the respiratory rate increases, PaCO2 goes down, but at some point it starts increasing again. So now I will show you the ABG book. You see, this is the ABC of ABG. You can copy this. You can copy WhatsApp, make a lecture out of this, and all that is possible. This I have shown you the understanding pH thing. So if I change the pH this way, the inverse relation can be very clearly shown. Let's see, pH, H1 concentration of 40 and pH of 7.4. Now, if I increase H1 concentration for 40, it goes this way, it becomes acidic. If I decrease H1 concentration, it becomes alkaline. And see the lower value, that depends on the pK of the solution. The Henderson-Hasselbalch equation can be seen here. Bicarb 24, PaCO2 40, and play. And you can see the equation getting solved. Can you see the screen?
Not yet, sir. Not yet. Please share again.
Yeah.
Yes, it is visible, sir.
Right. So I will take you to the book. So you can play with this, as I've told you, and every values would change and will give you what the pH would be. Okay. If you want to really have a wonderful time playing with this, see this graph. This is the only app to have this kind of a dynamic graph. And if you can see in this, the value of 7.4 is shown here and CO2 40, and you can see the red dot. Correct. Now, if I get into pH, which is acidic, so let's say I get a pH of 7.2, you can see the red dot has moved to an acidic range, and you are in the zone of metabolic acidosis. pH of 7.2 and PaCO2 of 20. Now, on this, so this will be a typical patient with DKA, pH of 7.2 and PaCO2 of 20. Now, he is in coma, and for some reason, he aspirates. And as he aspirates, his CO2 starts increasing. Now see how things change. please focus on the red dot below. His CO2 is increasing now, and now it's gone up, is going up, is now 72, and now he's in the zone of acute respiratory acidosis. I mean, he had DKA, metabolic acidosis. Now, because of aspiration, he's gone into acute respiratory. But see here, in this zone, he had a mixed acidosis, so metabolic acidosis and respiratory acidosis. I will again play for you pH of 7.2 and CO2 of 21, and this is pure metabolic acidosis zone. Okay. The fellow aspirates now, and because he has aspirated, he is in a phase of metabolic acidosis and respiratory acidosis. Let's go on to the alkaline side. Let's say the pH of 7.5. With this pH, if his CO2 is 19 or 20, he is in a zone of respiratory alkalosis. Is this clear? So if you play on this graphical format, you would be able to understand the dynamics of how the ABG changes. Now, these are the algorithms. The app is made of these algorithms. They are there for you to understand. So, somebody would have written these algorithms, but we have shown them very clearly. So, how the app is working is shown clearly in this. Now, I can show you a couple of cases, like this patient with pH of 7.42 and CO2 of 33 has respiratory alkalosis. So, friends, I hope you can see. I hope you can see here. Hello?
Yes, sir. Yes, sir.
Yeah.
We
Now,
can
what you see here is paradoxical respiration. Okay. And what you expect in this patient would be pH which is low and CO2 which is high. And since this is not something which has happened now, this will be chronic respiratory acidosis. Now, see this patient. This fellow was to be taken for some surgery, and this is a paradoxical respiration. So these are the kind of patients who will be prone for retaining CO2. Now this patient is an 18-year-old child, strider for last 17 years. The cause was bilateral abductor paralysis. The X-ray is very classical, shows elongated airy epiglottic fold. In fact, this X-ray I sent in for a pediatric radiology book, and they have published it as class X-ray of bilateral abductor paralysis. Now, this is a kind of patient. If his PaO2 is something like 56, and if his CO2 is 57 with pH of 7.38, even if his PaO2 is 56, this is a kind of patient whom one should be very, very careful in giving oxygen, because his respiration depends on hypercarbic drive. So these patients having these abnormalities for years together, they have got used to this. Even if their PaO2 is less than 60, they would have increased to 3 DPGs. they would have certain other changes in hemoglobin concentrations. They could have increased the perfusion index and would see that the oxygen is delivered to tissues. And if we mistakenly take that PaO2 value as something where we need to intervene and give oxygen, this could be dangerous. So some of these patients need to be very carefully handled. I think I would suggest that, I don't know, as chairman, you could take the call, because taking ABG beyond this may not be very easy. I think I could continue this lecture some other time, because beyond it will become even more complex. And my suggestion would be, we could stop here. We could be very alert when we take ABG. I have so many other things to contribute, but I think beyond this would be rather not easy for you. Thank you very much. But let me know. I'm open to questions. I have so much more to share, but I think beyond this would not be easy. That's what my personal feeling is.
Yes. Thank you, sir. Actually, what happened, many people have said some day, other day. I say, okay, we can do that way. So thank Deputy sir for this. I have only one question, which I asked by Dr. Minaz also. What about the standard value versus the actual value for bicarb, which we should take, or we should not take any value?
Yeah. Honestly, if you ask me, bicarb is the most useless thing in ABG. I will share with you.
You mentioned that, sir. Yeah.
I'll share with you an up-to-date reference, latest up-to-date reference. Okay. Which in fact, I'll just check. I have mentioned here. Let's see.
Okay. So we'll hello.
One second. I'll just share with you the.
Yes.
No, not yet. But anyway, so ABG bicarb, now standard bicarbonate is the expected PCO2, is the expected bicarbonate when the PCO2 value is 40, when the hemoglobin is 8, when the temperature, body temperature is settled. Now that is what a standard bicarbonate value is. In short, what it means is, when you set the PCO2 at 40, what the expected bicarbonate would be is what a standard bicarbonate is. But let me remind you that bicarbonate excess, bicarbonate deficit are values largely dependent on animal studies. A lot of those variables were not corroborated at that time, and thus they don't hold any value today.
Okay. So, Dr. Neha Singh, are you there for vote of thanks? Or I should go ahead. Hello. So, friends.
Hello. Yeah.
Yes. So, we'll wind up here. Right now, I think is almost 10:48. So, we are exhausted with our almost 2 hours, and we are still here to learn more. But I think probably we'll get another class at some other time, maybe under some other platform, regarding this ABG. So thank Dr. Depujay sir and Dr. Mahesh Moite sir for extensive, wonderful, and people learn a lot. In despite, I also learned something new today. Dr. Gangolia sir, the mastermind for the procedures, apart from with Dr. Jay Bhandarkar, who is the co-host for this. I feel very happy that we learned something new today in the Maha Speciality chapter. I'll thanks to the Maha IP chapter EP members like Neha Singh, Amol, Vishal Raut, Dr. Chitra Madam, and Dr. Renu Borakar, who remains there till last, and they're also learning a new things here. And a lot of stalwarts here. Dr. Minaz there, Dr. Srini Vaidya, Vishram Buche sir, Sushma Sai Madam, Bela Verma Madam, Narendra Naniwadekar sir. So there are a lot of people who are also expert in ABG, and they also giving thanks for having this wonderful session for today. Thanks to Dr. Basaraj sir also for remaining here till almost last, and for inauguration and also helping us to get this session for here for today. So thanks to everyone. Thanks to Pujari sir and thanks to the Mahesh Moite sir once again. and we'll like to see both of you in next some session. We comes every monthly on the second Friday between 9 to 10:30 p.m. with various subspecialties. Next time we will getting a very interesting sessions that will be on the hematology, and for this Dr. Nitin Shah has agreed for getting the sessions. So please continue watching on the Maha IP platform, Maha subspecialty. So here we are asking for experts across India to do their extensive expertise way of teaching the fellows. So crowd here is a pediatricians, and I'm happy today we have a crowd which contains people and fellows coming from UAE, China, Canada, and Australia, and almost hundreds of people also watching on the YouTube simultaneously. So thanks everyone, and thank you and goodbye for today. Bye bye.
Thank you.
For wonderful moderation. Thank you.
Thanks, Jay sir.
Thank you.